So let me spend a few minutes on some thoughts on death, bad death and good death, and also our possible role as medical professionals in the dying process. So we all know this. We all know that birth and death are part of the continuum of life. But birth is very often a happy and healthy event. But people generally do not consider death as a happy and healthy event. But can death be? Because this is natural. This is part of life. It is inevitable. If you are born, you have to die. We all know this intellectually. But again, why is death so unhappy and miserable? Can death be happy and healthy? This is something that we have to ask ourselves, especially in a society which more or less is death denying. And there are also people who think that the meaning of life is that it stops. This is a quote from Kafka. There is some truth in it, though this is literature. There is some. If the meaning of life or the importance that we give to life, or we realize the value of life, only when you realize that this is not infinite. Each moment, each hour, each second matters. When you realize that what is given to you, what we take for granted now, is not unlimited. The time that we have with us, though when we are healthy and active, we believe that, or we go on as if this is unending. When you know that this is finite, then you tend to see what we have with us as more valuable, and the time that is with us more precious, because you do not know what is likely to happen in the future. So this is the meaning of life is that it stops, is a quote from Kafka. And then also, this is about the inevitability of death. Like we have been talking about healthy practices, we have been talking about healthy food, exercises, healthy lifestyle. Yeah, it helps to live you healthy till you die, but it will not avoid death. Whatever you do, the interesting quote which says that no matter how zealously you drink your orange juice, eat your fruit and vegetables, organize your sleep and do exercise, the fact remains that one day you will be dead. But something that has happened, something important that has happened over the last 50 years, is because of the interventions in medical technology, because the advances that we have in medicine, the way people die have changed enormously, drastically. You will understand it only when you look at the way people have been dying 50 years ago, 75 years ago, and the way people are dying now. So the medical technology, with the current medical technology, you have options. I'll come to this, which were not there in the past. And this is something people have been thinking about death, and the medical science has also been thinking about death and dying for a long time. And this is a book from in Latin. This is Ars Moriendi, Art of Dying. This early 15th century, when the printing press was first invented, this was one of the 5 books printed, and it continued to be the bestseller for 200 years, 2 centuries till the 17th century. But something happened in 17th century in the medical science, which the first time till 17th century. The prolongation of life was not part of what we call our aims of medical science. It was Francis Bacon. He's not a doctor, he's a philosopher, author. He's the one who actually first time suggested that prolongation of life should be a task of medicine. So he was arguing that prolongation of life is the most noble of all tasks of medicine. That was 17th century, and within another 200 years, we took it up on us so firmly that today, this is another quote from one of the books, to say that doctors are allergic to the smell of death, because we have been taught to see death as failure, death as defeat, and we turn away from death. So this is something that has happened over 2 centuries within medical profession. And when you look at medical literature, medical textbooks, and over the last 100 years, less and less mention of death and dying or comfort during dying in all the textbook, all the literature. Many of the terminologies, also philosophically also, the way medical science has been looking at death has changed dramatically. And this is a very interesting question. I very often ask this to groups of doctors: would you like to die the way your patient die? And most often the answer is an emphatic no. Particularly, I don't know how you will respond as general practitioners, because you might have seen a lot of deaths at home also. Death at home is fairly much better than death in the hospital. But when you ask the question to doctors working in hospital, I've never come across an yes. People generally say that the cardiologist, I've asked this to cardiologists, I've asked this to intensive care people, oncologists, and they generally say no, I don't want to die the way my patients die. Which means what we're offering to the dying patient is probably not the best. And also, which also means that the hospitals are probably not the best place for people to die. Though people rush to the hospitals to die, probably that's not the best place to die. And there was a study, international study, a survey by an American physician in 2012, and it got published in many of the leading international newspapers. And they sent questionnaires to intensive care units, doctors working in intensive care unit, oncology, cardiology, and some of the general practitioners also. And they found that doctors prefer not to get into this. When you feel that you are about to die, when you are sure that you are about to die, generally doctors prefer to opt out. They don't want to be put on ventilator. They don't want to get admitted into intensive care unit. So this is something interesting. We know, within us, we know that what we offer to our patients at the end of their life is probably not the best thing. This has a lot of issues related to what we call our professional integrity and professional ethics, because if you know that what we offer is not the best, why do you offer it? So this is also a quote. This is a quote from Elora Fenley, my professor of palliative medicine. She has been saying that again about the inevitability of death. We have been saying that life is a fragile, though we do not realize it, life is a fragile commodity. As doctors, we come across a lot of instances where active, very, very healthy people suddenly get down, suddenly sort of go downhill, suddenly get diagnosed with life-threatening diseases. So this is a very, very fragile commodity, and we usually undervalue the good quality of life, and we with the belief that this will, when death and ill health and life-threatening diseases are something that usually happen to other people, and we believe that it will never happen to us. And it's very hard to imagine in the shoes of somebody who is about to leave this world, and but the world continues without, like, as normal or as so. And this is with some of you who have attended our sessions in palliative care might have come across these slides. Generally that only, and just reviewing it, and generally only 3 ways for people to die. A small percentage of people, 15% of people, die like this suddenly. A major heart attack or an accident or a homicide, some without any premonition, without being healthy, and then going down suddenly. The majority of us, this can happen only to up to 15% of people. 85% of people means, again, there must be around 150 people in the group, and then 130, 140 of us are going to die either like this or like this. A diagnosis, life-threatening disease and steady decline, predictable death, or old age, multiple diseases, in and out of hospital, and then they die. So these are only the 3 ways in which people die. So when you talk about death, the interesting thing is that this is probably the only topic which is relevant to, which is universal, which is relevant to all of us. When you talk about cancer, you can always feel that, okay, I may not, the chance of getting cancer is only 1 in 5 or 1 in 6 after the age of 40. So I may not get it. Or diabetes, you can say that this very, the incidence is rising, but I may not get it. But when you talk about death, you cannot say that I'm a doctor, I may not get it. No, we all will have to face this. So then, this is in a way, the first modality of death. So sudden death is so sudden that you don't get time to think about it. There is no fear of death. There is no worries about death. But the other 2, you know that you are deteriorating. You are seeing death nearby. And this is associated with a lot of fears. in the say that mostly when I talked, I've been seeing a lot of people. I've been in palliative care for the last 20 years, and then sort of I've been looking after a huge number of patients who are at the end of their life. And when we talk to people, what are you afraid of? Generally, they come under 3 categories of worries. One, the fear of the unknown. How will it be? How will the process be? And the fear of what will happen after this, fear of what we call afterlife, and the worries about what will happen to my family, what will happen to my relatives, what will happen to my dependents, and what will happen to my bank balance. These are things that you leave behind. What will happen to my property? And also worries of leaving the pleasures of life. We have been living fairly comfortably and then leaving this behind, and that's also a major worry. And then this is a cartoon which says that the death is on the side, and then somebody was saying that if you are really quiet, maybe he will go away. But no, he will never go away. This is applicable to all of us. And this is something that we all observe. Most people die in distress, but as a matter of fact, most people live also in distress. We live a very stressful life, and we have a stressful end. So this is just sort of, for a moment, just think about this. Why is dying so uncomfortable? There may be other worries and other issues. And also, since it is universal, just spend a moment to think about you. What are your worries about your own death? I don't want, like in the other session, we sometimes discuss about this and get feedback from the group and all, but we don't have time for all that. But just remember, just use this a couple of seconds to think about your worries. Your worries, because once in a while it's good to think about our mortality, inevitability of our death also, because that helps in keeping us more realistic and more empathetic to a patient. Because generally we have a tendency to see the dying person on the other end, the patient on the other end, and us on this end. But we are on a continuum. We are on a continuum with the patient. The other end is actually a reflection of what we will be in another year, another few years, another 10 years or 20 years. So just reflect on your own worries about your death. And also reflect on, we have seen 3 ways of dying. And not that we will get the preferred way, because only 15% can die suddenly, other 85 die either slow death or a turbulent course. But just think about it. How do you prefer to die? This is just a mental exercise to reflect on yourself and reflect on your body. As doctors, we usually do not get time to think about ourselves. So use the next couple of seconds to think about, because this is something that we all have to face. So it's very likely that most of us are, probably not me, because I have given it very clearly in writing that I don't want to undergo this, but most of you are likely to die in intensive care units. Because the way modern medicine has evolved, now people live much longer with a chronic illness, diabetes, cancer, cardiovascular diseases, stroke, everything, HIV, AIDS. The killer diseases are no more killers. They just keep you, the medical technology has the know-how to fight it and keep you alive in a much compromised situation. So we live longer. And also the dying process is also much prolonged. People used to die at home quickly in the past. Now you get shifted to the hospital, you get shifted to the ICU. You die on ventilator, you die on intensive care unit, you die on vasopressors, you die on various infusions and drugs. So this is something that has happened, and the dying process is also prolonged. So there was data from, we have now started working very closely with emergency medicine people and intensive care units. And this was data from some of the American intensive care units. They say that only 1/5 of patients emerge alive from American intensive care units. The other 4/5 die in ICU. Not because ICUs are bad, because the wrong people get into the ICU. ICUs are not probably the good places to die. And this is also another quote which says that even the ordinary methods of treating disease and prolonging life have changed the conduct in which men die. Fewer and fewer people die in the familiar surroundings of home or in the company of family and friends. At the time when when there is perhaps the greatest need for human warmth and comfort, the dying patient is kept company by cardiac pacemakers and defibrillators, respirators, aspirators, oxygenators, catheters, and the intravenous drop. Ties to the community of men are replaced by attachment to the assemblage of machines. You all know this. We are also part of the culprits. We know this. We have come across a lot of people who, instead of dying in the company of friends, relatives, and family members, die in isolation in ICU, in the company of strange faces and also all this machinery. And this is something very interesting. A bioethicist was suggesting that since medicine has given up or medicine has started ignoring the dying process and also ignoring the fact that people will die one day, and they created various technologies which can prolong life even in the dying phase. They just created a new difficulty for mankind. People now have to choose how to die, whether to die at home quickly. When you are 90 and you have COPD, chronic heart failure, then you have an heart attack, you can decide to die at home. Or you can decide to get shifted to the hospital, to the ICU. You may die in the hospital, or you may come back later and then go back after some time to die. Or you may die in the ventilator, you may die on an intravenous drip. So these are options. Now, earlier, 50 years ago, people did not have these options. When death comes, they die. Now we have options. With all these other new gadgets available, all the new medicines available, pneumonia, which used to kill very old people fairly quickly, now we can treat pneumonia. We treat pneumonia aggressively with the newer generation antibiotics and keep that person in the twilight with the area between living and dying for a long time. So this is a new difficulty that the medical technology has given to people, how to die. And this is also one of my favorite slides, which death in the past was more like analog clock. And after each digit, it's clearly black and white. In the past, people were either alive or dead. So, for example, the second one, the digital clock shows 11:13, and the next digit will be 11:14. There is no doubt about it. But look at the analog clock. Between 11:13 and 11:14, and the second needle moves. And there are a lot of time in between where you are neither in 11:13 or 11:14. So they were suggesting that death has become a gray area. And you do not know whether this person is actually living or actually dying. So this is a quote on palliative care, but palliative care is not just about death. It's about incurable illness. It's about improving quality of life. But it plays a major role in the dying process also. And also Dr. Jan Sternstad is familiar to some of you because his wife he was the head of cancer and palliative care at WHO for more than 15 years. And his wife is actually from Sri Lanka. Jayanti, a very, very good friend of mine. So he was saying that, this is a quote from Jan, you're saying that death is not a pure medical issue. Cultural and socio-economic factors determine what kind of death we face. So this is an area where we have a role, but we have to work closely with the other agents in the society. And this is something that many of us have realized over the last few years. Long time. We have been working with dying people for a long time. The only guarantee for comfort is the meaningful relationship. Even if you have a lot of money, even if you are powerful, even if you have a lot of knowledge, that will not help in the last phase. Something that we found was helpful was a meaningful relationship, but that's something to do with the general setting, the community, the sensitization of the community, sensitization of people. But we also have a role to play. What's our role as professionals? Because anything related to health, illness, or dying, or birth, doctors seek our advice. People seek our advice. The community generally look at doctors as experts in these areas. And can we do anything to make death and dying good, or may not call it good, or more comfortable? Yes, I think we can. So first of all, the basic ethical dictum, first of all, do no harm. This is a quote from Eric Castle, a US physician who has been writing a lot in New England Journal of Medicine on suffering. And he says that physicians' failure to understand the nature of suffering can result in medical intervention that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. This is more appropriate in the case of the dying person. End of life care. Our intervention, let's make sure that, let's look at the intervention, think about the intervention before we suggest an intervention, and let's make sure that we are at least not causing harm, do no harm. This is the first step. The second step is doing good. We are capable of doing good. The medical technology has a know-how to address most of the physical symptoms of the incurable patient, most of the physical symptoms of the dying patient, but unfortunately, because we are not taken efforts to master it, we have not taken efforts to apply it, most people still live and die miserably. So I'll come to some of these symptoms which we can address. But basically, when you look at holistically, the whole picture, there are three ways of dying with dignity. Some of these are not legal, but for completion's sake, I'm just mentioning all the three. One is the first one, letting people die naturally. But this involves a lot of sensitization of the community, because the society generally has become death denying. People deny death. People see death as secondary to something. Even the 95-year-old person getting admitted to the hospital, the first question that you are asked would be, is there any hope for prolonging? So they think that death is secondary to something, and if you can avoid that first thing, primary cause, death can be avoided. So it's a death-denying society, and there is a lot of pressure on family members to take the patient to the hospital, even if they know that the patient is dying. So it needs a lot of sensitization, but that may be one option. If people are sensitized, people are aware, and there is a medical system which support people, letting people die naturally. Second one is palliative care. You try to address the physical, psychosocial, and spiritual symptoms as much as possible to make the dying process more comfortable. Third one is not legally acceptable in most of these countries, but globally, some of the countries, euthanasia and physician-assisted suicide. Euthanasia is not acceptable only in a few countries. Physician-assisted suicide, in which the doctor plays a less active role by just giving a prescription. This is getting acceptable in many of the European countries and some of the states in the US. I mentioned it only because that to complete, if you search a net with dying with dignity, the phrase dying with dignity, you'll come across more of euthanasia and physician-assisted suicide sites than palliative care or letting people die. So generally, again, as I mentioned, if possible, keeping the patient at home is the best option, because hospitals are not the right places for these people. The usual trajectory, when somebody gets admitted to the hospital, the usual trajectory, when you admit the patient with the intervention and start intervening with the hope of recovery, and the treating team, even at some point the treating team realizes that there is no hope of recovery, we mechanically continue on the same track, same IV fluid, same investigation, same x-rays, same antibiotics, though we know that this is futile. So this is the usual course, but certain instances, if you realize that this is futile, there are options. There are options like what we call controlled death. It's difficult ethically, difficult to take a decision because there are a lot of dilemmas involved, because involves withholding some of these measures, futile measures. So legally you're okay, ethically you're okay, but emotionally this will be very difficult for the family members and for the doctors to consider. Withholding life-sustaining measures, withdrawing life-sustaining. We already started the patient on ventilator or nasogastric feed, and do you want to withdraw it? And also shortening the lying process is something that we don't do, but some of the European countries. So these are the issues within the hospital. So once the patient is in the hospital and in the hospital to die, things become more complicated. Complicated in the sense that the doctor will have to decide whether to start something or to stop a process, and it will have to be done in consultation with the patient and family members, and this is a very emotionally stressful procedure. And there were a few studies which, again, people who knew that they were dying, there have been studies which researchers asked people what do they want. Well, these are the list of actually the main 5 points that emerge. People wanted good pain and symptom control, and they wanted to avoid inappropriate prolongation of dying process. They wanted to achieve a sense of control, which very often do not happen in most of our hospitals. And we wanted to relieve the burdens on the family, and also they want to strengthen the relationship with loved ones. And this was a list of preconditions for a good death published by a healthcare and study group of the elderly people, age concern. I don't know, this is European, basically from UK. When we were discussing with some of our patients and family members and relatives and doctors, and some of these things, there were different opinions. For example, whether awareness of approaching death is good or bad is a precondition for good health is controversial. But knowledge of what to expect in the dying process, good symptom control, available to spiritual and emotional support, ability to make decisions with regard to care and place of death. Patient usually in our situation, patient is never asked. Patient is taken to the hospital, that person is shifted from one place to other. But what does he or she want? And to have time to settle unfinished business, and to say goodbye to loved ones, and not to have life prolonged pointlessly. So these are some of the factors that some of the key conditions that emerged. And when you look at palliative care, basically, palliative care is not just terminal care. Palliative care is not just caring for the people who are dying, but it is part of it. The philosophy of palliative care, improving the quality of life of patients, whichever state the patient is, whether curable or incurable or dying. We believe that the patient has a right to good quality of life till the last moment, and we should not intervene to reduce that quality of life or cause more suffering. So, and also we should be able to help facilitate the process of good quality life for the patient, whichever state the patient is in. If the patient is old, or if the patient is actually about to die, or the patient is having incurable illness, there's no reason for us to ignore that patient. So generally patients with progressive incurable diseases, and the care need to be interdisciplinary, and good management of pain and other symptoms. And it can include, this is not against curative therapy. We are working closely with curative therapy, so that even with curative therapy, the quality of life is much better. And psychological, spiritual support, and when the patient dies, there is some option for bereavement support. So the focus is mainly on suffering, relieving suffering, and improving the quality of life, and not on a particular disease process or not on a particular pathology. So this is what I have to talk to you about, basically about a few thoughts on the dying process and the good death and bad death. Basically our role would be to avoid unnecessary intervention, and also to take care of symptoms, to facilitate intervention by people who are willing to help and people who have the expertise to help, and also make sure that we don't compromise on the quality of life. We don't ignore the patient even when they are incurably ill, or even when they are dying. Thank you very much.